Okay. Okay, welcome everyone, and let's go ahead and take a look at the minutes from the August 6th, 2020 meeting. And when you're ready, someone give me a motion. We'll
Jason on the phone, move to adopt the minutes.
Okay, all in favor say aye.
Well, I second it and say aye.
Aye.
Okay. All opposed say nay. Hearing none, it's passed. First thing I want to do is give you an update on Dr. Potts. I talked to Barbara, and she's still very concerned about him. He's still at the hospital at research, and he's better and he's improving, but very slowly. And she said that they're still waiting for a place with a room where he can be helped to be weaned off the O2 and the oxygen. And so that's their present state. And he's very, very weak, and she said so. Anyway, she said that she and Don are very grateful for any thoughts or prayers that may come their way from our group, but told her we'll keep in touch and make sure that he's doing okay. If everything continues to, he'll be slow, but he'll probably make it. He's tough. Any has anybody else heard or talked to him, or? Okay. Well, that's what his status is, and so let's go on. The reason for this meeting primarily is to take more time for preparation to deal with this COVID-19. And Jason was visiting and said that maybe we could increase the number of the frequency of our visits so that we could do a better job of staying in touch with the constant evolving data and information available for the COVID. And so, we're not doing anything specific. We talked about it a little bit, but we'd like to go ahead and maybe tonight see what your interest is in terms of being a little bit more proactive and learning more and being better prepared for making future decisions. And I'll just open it to the floor, and anybody want to comment on anything? Have any thoughts you want to share?
But Jason here, and I'm not the expert. We've got several very good physicians and a lot of real good nurses. It's a good clinical group to engage the topic. But I just wanted to note from my observation of the world was that we're well into this, but there may be a second wave. The vaccination process may drag well into 2021. So we're going to live with this issue for a while longer. We have some new members of our council, and some members of the council have been asking questions of where does the city go with their decision-making process, and this is the technical body that ought to be weighing in to provide some feedback. So we've all got way too many meetings in our lives, but it did seem like at this point in time, getting you smart folks together to review what is the testing rates, the infection, the positivity rates, the fatalities that we've seen, what's the trend lines, how do we measure so we can provide advice and thought to the policymakers. And so that was my intention. And I'm going to chuckle here because I'm not technically competent. I can ask questions, but you all are the smart ones. So I thought to myself, it's always nice to volunteer your friends for more work. So in a way, that's what I got to do. So I'll go and mute now.
Well, Dr. Terry Morris, I think you're probably our surprise guest expert, specialist, and guru coach for the virus. And so now that you've been volunteered your efforts and stuff, you've already been working at it, so you're probably the best person to pick on. So, what
Yeah,
are your thoughts?
oh, it's this week's data was real interesting. Uh, I do have a question that I'm not sure how to answer. Uh, if you go to the county's website and it looks at hospitalizations, we don't have any data since August 7th in regarding to Eastern Jackson County. But yet, if you look at the 9 county average, it gives us hospital data. So, Christina, do you know, is Eastern Jack in that?
Yes. So what Jackson County was doing is Jackson County was trying to be specific to their residents, not necessarily the hospitals that were within Jackson County. So if you go to Mark's data hub,
Right.
they will specifically say how many patients, with COVID are being treated in hospitals in Jackson County.
Okay. So,
But Jackson County was trying to get that information, well, from the state or directly from case follow-up. And they apparently are having some issues right now with data talking to each other through the state, I'm told. And so that is why that has been unavailable.
yeah, they give us a big splash that says the state of Missouri recently went through a transition to do a new software, basically. And I just love how big chains and big organizations buy software and they think somehow magically it's going to talk to the other software when all of us who have ever done that knows that never works. Um, so if you look at the regional dashboard, it's a good news, bad news kind of thing. Our daily cases are down. We're at 246 a day. We're down 96. Our death rate is down 6. We're down to 1 death per day. 2 weeks ago, we were 6 deaths per day. Our ICU beds are stable. The number of people on a ventilator is down about 10%, down to 30. Average number of people in the hospital is down. We're 279. And that all is good that it's trending that direction here in Kansas City. The bad news is that's still a whole bucket of people that are ill. The bad news is our testing is down. Our weekly testing is down to about 13,000, and we're down almost 900 per week. And I'm not sure why that is, if it's an availability of tests or a reagent. I know some of the practices are having trouble getting the test materials.
The county and Mark, when they have their meetings, they've discussed the testing being down because their target is to have around 3,000 tests per day. So they're 1,000 tests per day lower than they want to be for the region. And even they admit that 3,000 tests per day would be the absolute minimum that we should be shooting for. But they point to multiple things, whether it's testing kits. A lot of it, they say, is just they're having problems getting people to come out. Some of that may be that when we've reached out to different groups, they say, well, it's not convenient to get tested. The testing clinics are are not over lunch break during the day when I have to be at work, and not, there's no evening or weekend hours and I can't afford to not go to work. And then they also talk about there are some that are fearful of going to get tested because if their fears are correct and they're positive, then that means they can't go to work. So there are a lot of people who don't want to go because they know that they may lose income.
And that's the huge dilemma of mask wearing and everything else. Missouri's running about 42 to 45% wearing masks. You do better. You see better than that if you walk into Walmart or Hy-Vee or what your grocery store of choice. But the stats are we're not quite 50% mask wearers. And I think Dr. Bix, when she was here in town, wasn't particularly enamored with that. I think my biggest concern is 14-day percentage rate of the test that we do is almost 13%. And statewide, it's 11.7, almost 12%. And that's probably because we're testing the people who are sick and not testing the overall. But it does put us in a hot spot. I've got a relative who lives in Texas that was going to go camping in Arizona, which is fine, except that you have to stay confined to your tent for 14 days. Once you get to Arizona, you can't get out of your tent. So they decided not to camp in Arizona this week.
Just as an aside, I run the numbers every other week for the council. And this last week, which had the information for the previous 2 weeks, we had one zip code that had a 23% positivity rate. So, I mean, I know that it's around 13% for the region, but we have zip codes that are just astronomically higher than they should be.
So the big question for all of us, is there anything we can do to impact that? Ralph, you said something about the changes in COVID cases. And if you look at the United States as a whole, in the last 2 weeks, we're up probably 15% as far as our incidence of COVID. Europe has taken off already. And so it's a little too early to tell because we're only 2 weeks in as far as whether this is going to be another peak. The IMHE data says that this really is probably going to take off first week in November or so. And at that point in time, we're going to have more sick people than we do hospital beds. Part of that's COVID, part of that's influenza. Although
how's the influenza coming along? Has it started to peak? Has it started to take off, the influenza time frame?
Yeah, usually that's October, November, kind of peaks in December. So now that we've got everybody back to school, that's kind of when this starts to peak off. And that's why they're thinking in November is when we're going to, and actually their prediction is that we're going to be out of ICU beds probably the first week in December. So we're just going to have to see how that goes. I unfortunately don't see an improvement. The isolation fatigue is getting pretty severe, and people are just tired of doing that. And oftentimes we let our sentiments outrule our better judgment and get into trouble. So right now the data says we're probably going to have a peak, and it's probably going to be in October, November.
So what are the thoughts about making a change in our number of meetings and being a little more engaged in this journey with the COVID virus? Any comments?
So what would we want them, what influence are we hoping to have by meeting more often on the policymakers? A frustration aside for me is just simply, it feels like people have gone into their camps. I'm a mask wearer, I'm not a mask wearer. If I have to wear it, I'll wear it. I'm going to live my life the way I want to. So it just feels like it's part of that fatigue that was discussed. But what influence are we hoping to have, or what information are we hoping to take to policymakers that is going to change our current predicament?
Hey, Jason here, and excellent question, and a fair one. The city's authority, and Christina may correct me here, is over its properties and its use of city resources for engagement with this. So the city does enforcement actions within the city boundaries of the mask effort. They also have rules affecting city properties and such. So the question some city policymakers have had is it time to roll back any of those efforts? So if the city were to decide to step back from its current level of involvement, then the county would take over enforcement, and I think that would be less than what we've got today, quite honestly. And presumably that would mean you could enter city buildings without masks, et cetera. So I think and I certainly don't want to tell anybody I think all the policymakers are going to listen to a technical committee, because that has not proven out nationwide. But I think just from listening to today's, one of the questions I was going to ask is, do we have something to report from a review, whether it's monthly or bi-monthly, that we should be sending a simple message of at least the Board of Health has reviewed the available information, and we recommend you maintain the current level of vigilance with regard to the COVID-19 pandemic. Or we would recommend you consider some other changes to improve our response, or it seems like it's time for a serious discussion about rolling them back. I mean, I would advocate at the end of the conversation tonight, we send a short, simple message. Christina, did I frame the policy option correctly?
Yes, I mean, we do without local public health authority. We are under the county's orders and mandates. However, currently we are choosing to enforce those orders ourselves within our boundaries. I'm sure that we could very well, turn a blind eye if someone is not wearing a mask inside our facilities. But right now we are choosing not to do that. And we are being proactive and trying to do what we believe is best. However, there are things that the city just very strictly does control that's under our purview and not the county's. And those are our facilities. Making decisions about when we reopen fully are things that, I mean, I know council members have asked whether the Board of Health has an opinion. I can't promise you they're going to, take every opinion you guys suggest and run with it, but there are at least some that would like to hear.
Hey all, Daryl Nelson. I joined a few minutes late, so happy to chime in if there's any particular feedback you want from our perch.
Welcome, Daryl.
Yeah, well, Daryl, we
Thanks,
were
Rob.
talking a little bit about the 2-week trend where the sickness appears to be getting better, although the overall bed use is about the same, and the predictions from the people that are all smarter than us that this is we're at the beginning of another peak. Had the CMO's been talking about that as well, and is that what they're hearing?
Yeah, Terry. So I was on the citywide call last Friday, and the next one is tomorrow morning, and that's hosted by Steve Stites at KU, and we meet weekly, and there's an informal report across the city about hospital beds that I haven't seen any data that matches up to it, to be totally honest with you, but I know those are the people who know how many COVID patients are in their hospital, and that trend has been gradually down, but not dramatically. For the HCA health system, we're currently at 42 inpatient COVID with 2 on the ventilator. Our peak was 67 back in the middle of July. All the health systems last week reported that mid-July has continued to be their peak. KU forecasters, the epidemiologists and statisticians believe that we're going to see a peak starting, or a trend upward, starting, and maybe this is what you're hinting at, you're starting to see, Terry, in the data you're watching, next week into the first few weeks of October, driven largely by the Labor Day holiday and school openings. But what's different, they believe, is it's going to be 2 communicable incubation periods out. So they're thinking the younger population is going to have been exposed through Memorial or Labor Day activities and school openings, transmits that potentially to parents, and then parents to the more seniors. Nobody has any idea if that forecast is accurate. Our colleagues at the university have admitted they've been like the rest of us, wrong as often as they've been right, but that's what they're projecting. They're also watching some social tracking data, which I think you were alluding to right as I got on, Terry, about trends with masks, mobility, some of the kind of global tracking data that's happening out there, maybe somewhat unbeknownst to all of us, but is occurring. And we look like we're significantly trending into a higher mobility state in the Midwest, and many potentially believe we may be headed there. Some really interesting data across our company. HCA is in 24 states and 55 unique service markets. And we are at an all-time low despite being in some of the hardest hit areas in Florida and Texas. We peaked again back in July with 7,200 inpatients. Report as of Monday of this week, we had 2,150 inpatients across all of our hospitals with acute active COVID-19 illness. I don't recall what the ventilated rate was. So I realize that doesn't marry up with some of the nuances also you were talking about, Terry, and community-based testing. Obviously, we're tracking more what we're seeing in the higher level of severity of illness, trying to prepare if or when that trend starts to escalate so that we can somehow be ready institutionally. So fascinating information from a regional CS rep and the chief of vaccine development at Children's Mercy, who were guests on our call last week. And they said, somewhat off the record and all politics aside, there's not going to be any COVID vaccination.
Oh, man.
Where'd you go?
Hello? Daryl?
Nothing like hanging there.
Still got me?
Oh, just at the moment that he was going to talk about the
I'm
critical
back.
information.
Oh, he's back.
I'm back. Yeah, my phone just flipped off my head that I was talking there. So the interesting information from the chief of vaccine development and the CMS rep were that there's, in their opinions, not formally for the record, that there won't be significant, if any, vaccine into the market deliverable that's vaccinatable until the spring of 21. They said there's a couple of nuances that Washington could try to implement and maybe drive some there. But I didn't even realize our current chief down at Mercy had been at Stanford for years and has been one of the lead investigators on a number of different vaccine development trials. So she's considered an international expert. Name escapes me now, but she lost me really quickly when she did the technical part, and then she pulled back to kind of the practicality and the epidemiology. So her opinion and the regional CMS physician leader, not the administrator, both believe that these pushes to ramp up vaccination plans are premature. Again, could all be wrong, and somebody may have something happening because, Terry, like you said, I got from my state academy and from the Department of Health both a hospital survey and a practitioner survey asking what my capacity was to do COVID vaccination. So, I mean, people are ramping up, and there's probably nothing wrong with that. I'm just not sure about the viability and the willingness of folks, as you alluded to, from some of the infrequent but real complications that are, always seen in the early phase trials about are we going to rush this, if you will, to market? And I just don't think we know, but it was really interesting that kind of informally a couple of folks pretty tight in the know in the U.S. vaccination trial community are thinking we are still months away. So I guess we'll, just have to wait to see what comes from that perspective. The last thing, probably some of the most fascinating data I've seen in my 30 years of practice, was presented last week on a nationwide call hosted by the CDC on forecasts for influenza. And Terry, you may or may not have seen this. The Morbidity and Monthly Report published September 18th carried Southern Hemispheric influenza data, and it was apparently the first formal publication of what their experience has been down there. And that usually provides a pretty good line of sight about what influenza is going to look like in the U.S. because we obviously are kind of 6 months off as far as our season. And the incidence of positive influenza tests in Chile, South Africa, and Australia across the peak months of the influenza season in their country was 0.33%. And they overlaid that with the past 6 years of influenza data, and there was nothing even close. It was in the teens and the light years up to 30%, if I recall, in the heavier influenza years. All they believe predicated on the social distancing, masking, and they were more draconian in their countries, I would say, with some of the mandated quarantine orders than here, but I still think there is some overlap. So it's really interesting to think about if that may play its way out. We've started our flu vaccine clinics at the hospital on Tuesday of this week. Our participation so far looks about like it has in previous years as far as employees coming to get their vaccines. We require either you vaccinate or you document a declination as a part of our influenza vaccine policy. That's been for many years in our company. So we'll know more as we get farther in here, kind of what at least a community of 1,500 healthcare providers are going to contemplate about flu vaccine. We've heard some noise that some may opt to pass this year because they believe the other preventative strategies in place are going to be adequate to protect them, since we know our flu vaccine program is usually 40 to 70% effective in strict numbers. So I think there's just a lot of like, wow, how do you kind of put all this together in answer to the committee's question about how can we be more beneficial? And just so you know, what you're contemplating, Christine and Ralph, is exactly what the CMO community is to try to take a non-political stance and host with Mark a couple of weeks ago a news conference that just implored people to continue to be attentive to infection prevention tactics and strategies. We have no interest in getting drug into the political debate. We're just trying to reflect what we know from protecting folks from infections and applying that more broadly. So I certainly would be in favor of us being on the record as meeting and looking at the data and continuing to recommend that people be cognizant, not complacent, of trying to protect themselves and not, avoid trying to get drawn into the political arguments and debates. I've presented to a couple service organizations, and those folks you were just talking about earlier quickly were after me about, how can I suggest that out in public they need to be protecting themselves. So I just choose not to try to engage. All we can do, I think, is make recommendations and try to base it on the science we have, which is ever changing. I mean, I heard the other day dozens of clinical trials being released daily as it related to COVID and influenza. So it's going to be full time for you, Terry, with a little more time than the rest to try to keep up with it.
Yeah, I read an article this afternoon that was dealing with COVID studies, and I don't remember, it was 12 or 15 COVID studies had been withdrawn this week, and that they had published reports, and then once somebody finally analyzed the data, they withdrew the reports because they were invalid.
They're coming out so fast. They're coming out so fast. The fact checkers are having a hard time. Keeping up, because obviously none of this is randomized, double-blind at this point. So
a lot of the problems with the press is that it reports pre-published data. You can go online and find data that hasn't even been published in the journal yet, so it hasn't even been critically reviewed. One of the things I used to tell patients all the time was a fascinating thing. Most people know about the New England Journal of Medicine. The New England Journal of Medicine is mailed to the press a week before it's mailed to physicians.
Right.
So every once in a while, I'd have a patient came in and ask me a question that they saw on the news last night, and I had no idea what they were talking about because I hadn't seen that article. So it's challenging times.
Yep, for sure. So those are the high points that I was contemplating that I think have been newsworthy in the past week in the communities I've been engaged with. So Hospital continues to stand ready. We're continuing to centralize care at research, so we screen and send positives down there as long as they're medically stable to transfer, but we track the overall numbers. But if we were to need to, we can scale up. We have a unit that we managed COVID on back in the spring, and could do that if need be for the sake of our community. So we're standing ready right now as a health system, though. Our centralization process is working fairly well, allowing us not to scatter resources all over the city. It is very resource intensive to care for the patients who get sick enough to require admission. So.
Dr. Nelson, just a thought. What do you think is the potential for our group, our board, to be able to be influential or have some effect or make an impact in this effort with our community? And based on what you're you know, you've got a large population, not unlike a community. And so what do you think the potential is for having an impact if we make this effort?
Well, I think there's a reasonable chance. I don't think it's a hands down gimme, because obviously there's so many people involved and there are so many opinions in addition to facts that it is a difficult conversation to have. And even in our community of caregivers, there is a vast array of opinion. But I would suggest to you that the kind of level-headed sort who don't tend to be as reactive do tend to find their way toward more recognized sources, if you will. The problem is that, you know, we'll probably inadvertently or indirectly get, you know, tied back to the county. And, you know, they've struggled a bit here, frankly, with their status and with the community's optics, and even amongst the community of caregivers. So I think that'll be tricky to figure out how we walk that line, particularly if we have any recommendations. I'm not sure what they might be that would, you know, vary differently or significantly differently from any current published stance with the county. I will tell you, as a hospital system, we have continued to tie back primarily to the CDC. I know it's easy to, again, debate all that, but I found a lot of the resource experts that are outside of maybe of the public's eye and all the press conferences to be really helpful and can provide us clarification a lot of times. So we haven't very often had to go off the reservation. I'm not sure we have significantly with a lot of the recommendations that are coming out there, but I think cascading the message about just common sense, self-protective strategies, and still considering people to consider flu vaccine. And, you know, I think it's going to be hard to know what to recommend to people as far as when the COVID vaccine comes out and how they might respond. But I think we could have a potentially favorable impact amongst a subset of our community who look to you know, a group of community experts versus a single, you know, expert or some entity that's external to our community. But boy, it's sure hard, Ralph, to be totally honest, not to get lost in everything else that's out there. And, you know, this is a scenario that I think, as much as we try to leverage social media to help us with healthcare crises, there's a lot to combat there. We answer a lot to some of those things Terry was talking about that get either undue lead into the press or are just outwardly, you know, false news. And we spend some time wrestling that too. So, but I think we could have a potential impact. It's hard to potentially overstate it though, because there's just so much opinion and politicization about this topic out there that it'll be a big lift.
Well, you know, Dr. Morris, and I think he's, you know, all the conversations I've had with him, he's obviously been, sounds well informed and has a steady hand on the wheel. And so that, I think he's been fair in analysis of different opinions that I've presented to him about some topics that have come along, and so I think we've got a opportunity to maybe make a difference and help minimize the impact that might continue in the early stages until we get the vaccines up and running. And that's really the biggest issue, is what can we do between now and when the vaccines start to come out and take effect. And so that could be probably another year and a half.
Yeah, Jason, if you're still there, what is it that the council is interested in hearing? I sent a couple of them the link to the public CMO meeting from 2 weeks ago to kind of, because it was so well done, it was worth spending an hour sitting down and listening to people in a non-political manner. But what is it that the council wants to know?
So my opinion would be that I think this body could, if comfortable as a body, just indicate we've rediscussed the issue. We've got some topical experts that presented a wide array of information and data regarding our community, and we see no reason to roll back any of the protective provisions and policies that the city has put in place. So I think that something even that easy, short and direct, could provide meaning to. So the questions that have been asked is, should we be rolling back the provisions? So we have restaurants and bars and businesses that are limited on their occupancy, and we have city staff that is employed that are going out to check on that and such. So I think I agree with Dr. Nelson that we're not going to influence everyone, but I think if we're comfortable with that kind of a basic statement, I think that reinforces for many of the policymakers that we're doing our part for the community. They're paying us big bucks to come together and have these conversations and render an opinion, and I think that would have some meaning to some of them, to if indeed that's where we would coalesce around. I'm going to throw the ball to Christina to see if she might have any other suggestions. I'm not here to advocate for additional action. I think that would be an uphill climb if we knew what additional action to put on the table. I think we're more in a supporting what's going on today, so there's not an advocacy that starts up to roll things back prematurely. Christina, am I overstating what the policymakers might be interested in from us?
No, I mean, you nailed it on the head. The policymakers are, they want to know whether we should move forward in a phase, whether, we should lift restrictions, whether, I'm sure some, in all honesty, have also asked me, are there any other bright ideas? Are there any other things that we should be doing that we haven't done? As with anyone, there's 7 members of our council. And so sometimes it seems like there may be, at least 7 opinions of what we should do. And they're looking for ideas on both sides of, do we need to do more? Do we need to do less? And so any direction they could get would be helpful.
Okay.
Of a body, I would make the motion that I just earlier said, which was Board of Health, upon re-review of the available information for regarding our community, we recommend that there be no change in protective policies that have been put in place for our community at this time. I brought that off the top of my head, so please adapt it as you feel fit.
Any seconds to the motion?
It's Daryl. I'd second.
Okay. Any additional discussion or comments?
I think the only comment is that there really is no data to say that loosening things up is going to be particularly helpful. I think we've done pretty well the way it is. And I think we need to wait until another month or so is going to be very, very telling as far as when our second peak is going to arrive, if it does arrive. It's one of those, wouldn't it be a blessing if it didn't? But
Yeah.
that's not what
Nope, I
history
agree,
tells
Terry.
us.
Right. I agree.
And you have the overlap of the pandemic plus the influenza season. When that happens, then you got both of them impacting at the same time. That's going to be a challenging period. Any other comments? Okay, let's go ahead and take a vote. I guess maybe a roll call because we can't see anybody's hands or.
Maybe that, Dr. Ruckman?
Yes, I'm in favor of the motion.
Dr. Morris?
Yes.
Kathleen? Dr. Ruddy?
Yes.
Jason White?
Yes.
Shauna Jackson?
Yes.
Lori Halsey?
Yes.
Dr. Wingert?
Yes.
Dr. Nelson?
Yes.
And then Dr. Potts is not present. So motion passes.
Okay. Any other thoughts before? Let me take a look here and double check.
So are you talking about more frequent meetings? That would seem to be the other topic.
Yeah, that's what we were going to talk about next. Okay. Oh, and as we look at this, the monthly meetings, they don't have to be forever, because if we get to a certain point and we realize that we're not really getting any value out of the time that's being spent, obviously we can go back to the bi-monthly time frame. So this is just for this particular time period when we're have a problem that we need to deal with, and that's basically what this is all about. And then let's see, the monthly update, and then making recommendations to the city manager, the mayor, the city council. Okay. I believe we're right there where that probably would be the last thing that we need to take care of here tonight. So any thoughts about the additional meeting time frame and once a month?
But Jason here, I brought that topic forward, and how do we look at ask the clinical experts here available to look at it and sort of guide that question? I don't want extra meetings. You all are very busy too, but I just thought, how often should we take pause and reconvene to see if the data's taking the discussion somewhere else? And Christina, do you think providing advice to the council on a monthly basis is more frequent than would be of value to them? Would be the other question. So how often from a clinical perspective should we look at it, because of the fact it does change frequently? And the other question is, if we're sending them weekly things, does that make it more powerful than monthly or bi-monthly? And that question's to Christina. So those would be the two variables I'd throw out.
Well, currently, what they've requested for me is I'm actually providing an information-only piece for each of their regularly scheduled council meetings, which is the first and third Monday normally of the month. So they get essentially a purely factual data sheet by zip code for the City of Independence on those Mondays. That is their request, that it be semi-monthly. So that is what they are currently getting. I think they would appreciate once a month. That is the only time frame I've actually heard from them is monthly, to hear from the Board of Health. So I think they would be quite pleased if they heard from you monthly.
Okay.
Yeah, I think when you have a disease that has an incubation period of 2 weeks, you have to go out 2 incubation periods before you really see anything that's going to change the data. So meeting more than monthly is not going to tell us anything. I mean, we're not really going to know what's going on with schools reopening for at least a few more weeks. And I'm willing to do whatever the committee thinks is the right thing to do.
Okay. Any other thoughts or comments? Okay. Well, Christina, what is the technical aspect of having an additional, I mean, is a staff time something that we are going to, impose on, or is that something that is doable?
It should be doable. Staff are aware of the request from the council. So we will need to work out. Normally we would of course meet next Thursday for our normal meeting. I'm going to suggest that instead of meeting just next week, that we push that off a couple of weeks and slowly work our way back towards the beginning of the month instead of the end of the month. And that way it also gives the city staff time to make sure that they film the other public meetings that they need to be filming. Because we have to, since we can't meet in person, there is a little bit of a burden on the city staff to make sure that they can get around to all of the public meetings and get them all filmed and streamed. So I would suggest that we just push that back, but staff are aware and they will do their best to accommodate.
Okay. Okay, where are we now here? I guess it's time to take a vote. You want to do a roll call? Oh, we need a motion.
Jason here. I'd move we seek to meet monthly based on Christina and Ralph's determination of available space and staff and all those kind of variables. So approximately monthly.
I'll second.
Okay, all in favor, roll call. I vote yes, I'm in favor.
Dr. Morris?
Yes.
Kathleen Bennett?
Yes.
Dr. Ruddy?
Yes.
Jason White?
Yes.
Shauna Jackson?
Yes.
Lori Halsey?
Yes.
Dr. Wingert?
Yes.
Dr. Nelson?
Yes.
Okay, motion passes.
Okay. Any other questions before we adjourn? Okay.
I actually have one real quick.
Okay.
I'm not going to try to put anybody on the spot, but I know we were talking about vaccines and we're aware that a vaccine may not be available until this next year. That being said, the state has requested that any group that's interested in helping with vaccine rollout when it is available, that we get all of our information in by October 1st. And I'm sure that is a request because someone above them has asked that this get done. So we are needing a physician to be able to sign off on standing orders. If there's a physician amongst the Board of Health who is willing to sign off on standing orders for a vaccine, if you could email me, contact me, or speak up now, we would greatly appreciate that. One of the other requirements is, of course, some of the vaccines are required, depending on which ones are actually ever approved. Some of them are required to be kept at very cold temperatures, negative 70 degrees Celsius, I believe, for one of them. We do not have a vaccine fridge that will stay below negative 70 degrees Celsius. We do think that UMKC is going to share some of their freezer space with us, but if there are others who have access to space, we would love to know about it so we can make sure that we have enough space to do vaccinations. That is what I have to share.
Yeah, we've only got one freezer at the hospital that's -70, and it's got marginal capacity because of some tissue and other things we have to use in it. So we've seen that guidance. We're waiting for guidance from our corporate office about how to respond on that accessibility. We've also heard that the vaccine will likely ship in 1,000-dose, multi-dose vials, which is going to be something that'll have to be figured out how to be dealt with if that ends up being the case, between the temperature it has to be stored at and then how you manage something in that sort of a distribution entity. So, yeah. But I agree, Christine, that was my comments earlier. We're trying to figure out how to answer that survey as well. I think there's just so many unknowns. So probably just have to answer to the best of everybody's ability from that standpoint. I guess it's a little hard to know what to say about being the one to sign on to the first vaccination program as a physician, right? So most of the time you just put your name on those things and don't think a lot about it. So let me at least contemplate that and figure out what the recommendation of, our status is on those situations from a company and a hospital liability perspective. So happy to try to help. Normally would blindly just say yeah, but I'll investigate a little further.
Completely understandable.
Yeah, that particular vaccine, we had a conversation about that earlier this week. I mean, most vaccines are given in doctor's offices or in the parking lot of Hy-Vee or, and there's probably 4 or 5 places in the entire city that have a freezer like that. So just the logistics of trying to manage that is unfathomable. So.
Yeah, Terry, it's going to be a doozy unless something else changes. But like I said, there's just a whole bunch of these caveats about this vaccine that, the experts told us on our call is going to create a lot of logistics to actually get it to market. And again, I don't mean to be Debbie Downer on it. I just think I worry that the community picks up that this is coming, and the reality of it is boy, it's going to take some major intervention, divine intervention, whatever your beliefs are, that to make that happen as timely as some are suggesting, I think. And so,
So of all the vaccines out there, Dr. Nelson, what do you and Dr. Morris, what do you see as being probably the ideal or the best one that you would probably wait on if you were going to take the vaccine?
Yeah, I can't speak to it. I've not followed them that close. Honestly, Terry, it sounds like you've maybe tracked them a little closer. I've just at a very high level aware, as you pointed out earlier, of several of the really big developers are in process, but I haven't honestly followed them. Just managing too many other issues right now to be able to dig in when I feel like it's still a ways off. But maybe Terry has some insight.
No, other than the scary messenger RNA one, there's really no data out there to think about. I mean, today the chair of one of the committees from the CDC or from the FDA that oversees vaccine approval resigned because he's on the board of one of the vaccine companies. So, I mean, it's just, these are crazy, crazy times. So.
Yep.
Okay, in case I haven't done it, I'd say let's adjourn, and we'll be in touch with you and let you know when the next meeting is here in the next 2 to 3 weeks. Take care.
Thanks, Ralph. Have a good evening, everybody. Be safe.
All right. Thanks for everybody.
Take care.
Bye-bye.
Good night.